So what is dental implant? Dental implant is an artificial titanium fixture which is placed surgically into the jawbone to substitute for a missing tooth and its roots. According to the glossary of implant dentistry, dental implant is defined as a biocompatible alloplastic material or device that is surgically placed into the orofacial tissues and used for anchorage, functional, therapeutic, and or aesthetic purposes. The history of implants starts with 1930 Dr. Edward J. Greenfield. He came up with the surgical method to prepare a osteotomy in the healed bone using a trephine. He fabricated a hollow cylindrical basket, the root shape of 20 gauge iridoplatinum, which is soldered with the 24 karat gold. This was the first two-piece implant which separated the abutment from the endosteal implant body at the initial placement. So this is the picture. So this is inserted into the bone. Like he made a cylindrical basket of 20 gauge. It is made of iridoplatinum. It is soldered with 24 karat gold. This was done in 1930 by Edward J. Greenfields. So over this, he had placed a prosthetic crown, like how we are placing nowadays. The same thing he had done in 1913. The modern era of implant dentistry began in the late 1930s. First, Venable in 1937, he developed cast cobalt chromium molybdenum alloy as Vitalium. Then in 1937, Adams introduced submerged implants with ball head screws. 1939, Albin and Strock used a Venable screw type implant system. 1938, Strock placed the threaded Vitalium implant into the extraction socket. This was the first long time endosseous implant. It remained firm and asymptomatic for nearly 17 years. This is the Vitalium implant he placed in directly into the extraction socket. See, these are the grooves. It has a thread and this threads helps in osseointegration. The same implant system what we are following nowadays, the same thing happening here. So this was in 1938 by Strock. The history. In 1947, Formigny developed a single helix wire spiral implant which is made of stainless steel or tantalum. The two ends of the wire were soldered together to form a post or neck. See, this is the wire which is made spiral and it is soldered together. Two wire ends are soldered and the neck portion it's coming out. So over this we can take impression and we can fabricate the prosthetic crown. This was in 1947 by Formigny. Osseointegration. Coming to the current era of implant dentistry, this term osseointegration, that is osseo, the bone, and integrating with the titanium surface. This osseointegration was first coined by Swedish orthopedic surgeon Professor Brainmark in 1952 when he accidentally placed a titanium, pure titanium, into the rabbit bone for his orthopedic purpose. He was doing some study. When he tried to remove the titanium plate, it was so strong it didn't come out. So then he started exploring more on this concept, what had actually happened with the rabbit bone and the titanium. Then he found that there was a living bone tissue which formed between the titanium and the rabbit bone. Then he coined this term as the permanent biological adhesion and he given the term osseointegration. When pure titanium comes in contact with the living bone tissue, the two literally grow together to form a permanent biological adhesion. He was a Professor Brainmark. What are the factors for successful osseointegration? We should have a biocompatible material, titanium, either commercially pure or in certain alloys. Then we need primary implant stability. It should be precisely adapted to the prepared bony tissue. Then you should have a atraumatic surgery to minimize the tissue damage. And the implant which you are placing, it should be immobile. and undisturbed healing phase. These are the factors important for the successful osseointegration. Then biocompatibility is due to its surface oxide. When exposed to air, it forms a dense 4 nanometer layer of titanium oxide, which is the main chemically stable form, and it is the corrosion resistant structure. There are 4 grades of commercially pure titanium available, differing with the percentage of traces of impurities in the metal. If the impurities, that is the contaminants, are increased, the titanium will become harder. The greater the contaminants, the harder the metal. So grade 4 commercially pure titanium is now commonly used for dental implants. Grade 5 titanium alloy, they added along with the titanium 6 aluminium and 4 vanadium to the titanium alloy, and this is the grade 5 implant. It offers equal biocompatibility but better tensile strength and fracture resistant than the commercially pure titanium. Compared to the grade 4, grade 5 has good biocompatibility and tensile strength. Next to the titanium, now they are forming zirconia as well. This zirconia, it's similar in biocompatibility, improved cosmetics, fracture resistance is low, can be used only as a one-piece system. When you place the implant, the first bone formed will be the oven bone. It is formed quickly in the gap between the implant and the bone. It has a low biomechanical capacity, so the occlusal load should be controlled. That's why always immediate loading should be considered when you are placing in posterior areas, because the occlusal load will be more. If you are planning for an immediate loading, be careful the occlusion, so that the occlusal load is not maximum in the implant region. Make sure that after 1 to 2 months, under the effect of the load, the woven bone will slowly transfer into the lamellar bone. First will be the woven bone, then after 1 to 2 months, it becomes lamellar bone. Implant and bone interface. The glycoprotein layer on the bone is absorbed on the implant surface with the help of adhesive macromolecules like fibronectin and laminin. They are bonded to the metallic oxide layer on the titanium by covalent bonds, ionic bonds, or van der Waals bonding. The implant and the connective tissue surface. The gingival fibers forms the attachment. It's strong enough to withstand the occlusal forces and the microbial invasions. Why we need the implant connective tissue interface is that we need blood supply for the forming bone. So this gingival fibers, through the gingival fibers, we will get the blood vessels, the nutrients to form the bone. This is very important in the interface between the implant and connective tissue. Implant epithelial interface. Epithelium is attached to the implant surface through hemidesmosomes and glycoproteins, and it is considered as a biological seal. It forms a sulcus depth of 3 to 4 millimeter. See, this is the natural tooth. We have the crown portion, we have the root portion, we have periodontal fibers, the principal fibers of the periodontal ligament, Sharpie's fibers, and then we have the bone. This is in the natural tooth. But here we don't have the natural tooth. We are just placing a titanium screw. That is the implant. We are placing. You have the soft tissue. This soft tissue will have the blood supply. Then this bone directly osseointegrates with the titanium. So this is known as osseointegration. There is no fibrous attachment. Only through this soft tissue, we will get the blood supply to the bone, as well as for the osseointegration to occur only through the soft tissue. So while placing implant, make sure you don't damage the soft tissue. Make sure you don't affect the bone. If you drill without going in a gradual manner, see, if you are placing a 4 millimeter diameter of your implant, so you have to slowly go from 2.4, 3.2, 3.8, then comes the 4 millimeter. Like that, you have to gradually increase the osteotomy site. If you directly go 4 mm diameter and you just screw it, then this connective tissue, the bone interface will be affected. So keep that in mind. Slowly you do the osteotomy preparation. Do you get me the point, ma?
Yes, ma'am.
Okay. So classification of dental implants. We have the smooth surface implant, we have the machined, then we have the textured, then we have coated implant surface. This is based on the surface of the implants. Then classification based on implant design. This will be endosteal, then subperiosteal, transosteal and intramucosal. In endosteal, again we have ramus frame, then root form, then blade form.